Hey everyone. Today, let's talk about post resuscitation management. Now, you've worked very hard. You've done a lot to convert the rhythm and do all these chest compressions and everything that you've done for this patient. And now you have taken a patient without a pulse and made them have a pulse. So I know what you're thinking. I've done a lot of work up to this point. Now, what do I do? So let's break it down into best managing patients after resuscitative efforts. Now, there's a few things that we want to think about as we're treating these patients post resuscitation. The first big one is obviously operational, right? We want to think, of course, medicine needs to be performed, but without operations, without thinking of physically doing the medicine, then it's not going to happen. So, some things that we want to think about on the operational side are, of course, patient movement. So we need to think of how many people do we need to move this patient from where we are into the back of the ambulance. We need to think how many providers, what equipment we're going to need, if we're going to use the stretcher, a tarp. We're going to need some sort of mechanical chest compression device as well, right? We don't want to move them and then they happen to go back into cardiac arrest and we can't effectively perform compressions. So those are definitely some things that we want to think about when we're thinking of patient movement. We also want to consider our transport destination. So, where specifically does this patient need to go? Now, something to keep in mind too when we're looking at transport destination is, of course, what is this facility capable of doing that we're going to take this patient to? Of course, we want to consider the fact that they should have a catheterization suite or something that intervention can be performed on this patient. We also want to consider a place with an ICU. Of course, patients who were recently deceased and now have come back to life because of your efforts, they're going to need some sort of highly skilled providers and a lot of different critical care level medicine. And of course, specialized equipment. So if your agency or local department have some sort of ECMO or balloon pumps or any sort of specialized equipment that you guys are using or medications that you need to request at the scene. If you have physicians responding on your post resuscitation patients or certain medications that you have access to with that, definitely something to consider on the operational level. So, an operational thing is super important to think about after resuscitation has been performed. And we're kind of thinking those things as we're taking care of these patients and as we're dealing with those next steps of resuscitation. Now, of course, operational is just a little bit part of post resuscitation. The medicine is the biggest part that we're going to talk about today. First thing I want you to think about is taking a timeout. Blow the whistle. Tweet, tweet. We need a timeout. Now, why do we do a timeout? What's the whole point of a timeout, right? Well, ideally, we're going to spend about 10 minutes, just a 10-minute pause. What are we going to use those 10 minutes for? Our goal with spending that time out, taking those 10 minutes, is to stabilize the patient. We want to stabilize the patient before we move them anywhere. This is a critical point when we're resuscitating these patients and dealing with that post resuscitation is making sure that they are stable and ready to move before they potentially die on us again. When does death happen after resuscitation? Typically, it's within that first 10 minutes. So, that 10-minute period is crucial for recognizing what treatments we can do to best stabilize them and prevent that rearrest, or it is crucial to recognizing when they do go into rearrest. So, take some time, stabilize your patient, do a very good reassessment, and really the goal is to start over. At this point, this is a new patient. They're presenting to you much different than how they were presenting earlier. So we want to do a complete reassessment, right? Get a good physical assessment. Let's consider that underlying cause of what caused this cardiac arrest. Let's hone in on those treatments. Before we even do any of that, we need to start over, right? ABCs. ABCs is crucial to maintaining this person's stability and preventing that rearrest. So, airway, breathing, circulation. How can we best manage this patient's airway? Of course, we want to use an adjunct that's going to optimize our ventilation, right? We want something that's going to best optimize oxygenation and ventilation. Now, some agencies are using an impedance threshold device or something that increases that thoracic pressure and helps all the blood pump around. If you're using one of those, now's a great time to take that off. We don't want to be using an impedance threshold device in a person with a pulse. So, utilize an air junk that you can get a great oxygen saturation or as good as you can. Um, get as much high quality ventilations as you can. And our goal with those ventilations are about 10 to 12 breaths a minute. We do not want to be hyperventilating any of our patients post resuscitation. Our goal with maintaining the airway and breathing is an end tidal of 35 to 45. So, again, this is all ideal. These patients are going to be dealing with a lot of issues that cardiac arrest caused. So, do the best that you can for maintaining a good airway. And of course, this goes without saying, but we want to maintain homeostasis. We want to make sure that circulation and perfusion is happening. Let's talk about what we can do for that. All right, so let's talk about some big goals that we have post resuscitation. Of course, like I was saying earlier, maintain the patent airway. Whatever adjunct you're using, whether it's an ET tube, iGel, OPAs, or MPAs, maintain that good airway. Going along with that, we also want to maintain some oxygenation and some end tidal as well. So, as best as we can, provide as much oxygen as that patient needs. Our target between 92 and up for that SpO2. And of course, our end tidal, we want to try to titrate to a normal end tidal of about 35 to 45. Now, I hit on circulation a little bit earlier, but there's some things that we can do to best help our patient post resuscitation. And of course, one of the more important things is preparing for the best and preparing for the worst. So we want to be sure that we're prepared for that rearrest. We also want to be prepared for positive improvement. We did a lot of work. We provided a lot of antiarrhythmics, and those can do a lot of good for those patients in cardiac arrest. So it's really important that we're preparing for not only the rearrest, but some positive improvement and what we can do for patients when they experience that. Now, to maintain circulation, there could be a bunch of problems that cause this cardiac arrest, or those H's and T's. So think of what caused this cardiac arrest. Why did this person's heart stop beating? And why did we have to intervene the way that we intervened? So, of course, there's a few things that cause those cardiac arrests. And post resuscitation, if we get this person back, if we weren't already doing this intra arrest, we want to think of a couple things. If there's a fluid problem, let's replace it. If there is a true volume problem or a lack of it, let's replace it. Now, if this is traumatic in nature, your patients may best benefit from blood transfusions. If this is more of a hypovolemia, saline or lactated ringers or the appropriate replacement therapy would also be great. If there's a pump problem, a physical obstruction to the pump, or something causing the decreased pumping efficacy of the heart, of course we want to support it, right? So giving those beta 1 agonists like dobutamine or dopamine, something that we can do either chemically or physically support the pump and the pumping actions. Now, there can be some vascular problems, right? Some diffuse vasodilation, maybe with anaphylaxis or sepsis or some sort of distributive shock. If that's the case, we want to fix the vascular problem by causing vasoconstriction. So give those alpha 1 agonists and provide the vasoconstriction to help those peripheral and um, proximal vasculature and help constrict it, help build up those pressure. Maybe it's not so much a fluid problem, but maybe the container it's in is a little bit too big. Now, a rate problem. I want you to be cognizant of the rate problems. Arrhythmias are very common post resuscitation. Of course, I mean, you literally just got done shocking it and doing compressions. So give it a second, give it a minute, and reassess. Now, if that rate or arrhythmia problem continues and they still have a pulse, then of course manage it in those appropriate methods after you've given it some time to let the heart relax. Our goal with maintaining that circulation and maintaining that perfusion is a systolic of 90. This person was just dead. Do you expect them to return to a normal range of that 120 over 80? I wouldn't. So be cognizant. You're trying to go for a systolic of 90 or a MAP of 65. You're not trying to correct them to a 120 over 80 in normal hemodynamics. So I'd like to get into the preparing for rearrest and some things that we can do to best prepare for this being the case. Of course, we want to make sure that we're assessing our patient physically on top of the electrical activity and everything that we've just fixed. So at all times, we want to have someone with a finger on the pulse. Yes, somebody should have a finger on the pulse at all times. Why, you might ask? That's so we can best identify rearrest. When that person loses that pulse, we know that that person is no longer perfusing, or there is such a lack of perfusion that they are no longer having pulsatile beats. So we want to have a finger on the pulse and make sure we can recognize that rearrest as fast as possible. We also want to keep an eye on the monitor for any sort of rhythm changes, any sort of end tidal changes, increases or decreases. We want to make sure that we're being aware that this person is very susceptible to rearresting. We want to make sure that we have people watching the monitor at all times. And if your agency or department has one available to you, I'd recommend placing a mechanical CPR device just in case. Now, we can stabilize these patients for 10 minutes. We can take that time out and we can prepare them to move, but rearrest can happen at any point during that post resuscitation care. So, having that mechanical CPR device on and ready, but not obviously using it if they have a pulse, is super crucial to helping prepare for all those things in the event that they happen. Now, let's talk about the positives. Let's say that we've done all the things and now we can look out for some positive improvement that our patient may have. One of the most positive improvements that they can have is we've restored so much perfusion and we've restored their circulatory system that their brain is perfusing. So we may induce some consciousness. Now, consciousness is great, right? That means that our patient has done a full 180 from unconscious and pulseless to alert or conscious. It's good. That's great. Um, but in most cases, after resuscitation, we're going to have an advanced airway in place. Our goal with that advanced airway is to maintain that SpO2, the oxygenation, all the ventilation stuff. So, with them being conscious, that is going to affect our ability to maintain their airway. So, of course, the first thing we want to do is manage their pain, right? If we're going to keep that advanced airway in place, we need to make sure that we're managing the pain. One of the biggest things that can be caused when we're inducing so much pain and stress on the body is a catecholamine release. That's not good for our patients. We know that when that catecholamine release hits, all those things happening in our body, that creates more stress on the heart. And of course, what just happened to the heart? Exactly. You're following my point. So, more stress on the heart is more worse for our patients. So, we want to prevent the catecholamine release and manage their pain first. And of course, coming in with that pain management is also sedation. So let's keep an eye on the heart rate. Let's make sure that um, if they are conscious and if we're trying to treat that pain after resuscitation, one of the best indicators we have for somebody experiencing pain is their heart rate, those physiologic signs of pain. So keep an eye on that, right? Make sure that we're monitoring for the pain and anxiety post resuscitation because we know that that pain and that anxiety is going to create that catecholamine release and can end up stressing our heart even more than it already was, sending them back into cardiac arrest. Now, one of the best medications that we have to manage both pain and sedation is ketamine. So, if your agency has ketamine and you can use that post resuscitation, that is a great drug to use to help with both the pain and sedation post resuscitation. Now, let's wrap it all up. I like to summarize with a few key things that I'd like you to take away from this. Of course, this goes without saying, continuously reassess your patient. Intra arrest, post arrest, pre arrest, any patient, we want to continuously reassess. One assessment is not going to cut it. Physically, vital signs, everything you can do, reassess your patient. When we're talking about post resuscitation, we want to make sure that we're preparing for the best and the worst case scenario. We want to anticipate that this patient's going to make some positive improvements. We want to prepare to manage that pain and anxiety and sedation. We also want to make sure that we're preparing for the worst by anticipating that this person is going to rearrest. Of course, post resuscitation, we want to manage the ABCs. We want to look for the H's and T's. Uh, get an additional 12 lead. Let's look at the heart's electrical activity. Reassess everything. Find out what caused this cardiac arrest and treat it. Intra arrest and post resuscitation. We want to make sure that not only we're treating that after the fact, we can also prevent another rearrest by managing those H's and T's. We want to provide the appropriate antiarrhythmics, right? Of course, we know that arrhythmias are prone to happening post resuscitation immediately after the heart tissue is really aggravated. So give it some time, but after that certain amount of time, consider treating those antiarrhythmics appropriately. Again, when we're monitoring those antiarrhythmias, or we're monitoring those arrhythmias, make sure you're getting a 12 lead EKG a couple minutes after that cardiac arrest to best assess that tissue damage. That kind of goes in with those H's and T's. And of course, transport them to the appropriate facility. Take them to a facility that can best care for the events that happened. PCI, ICU, all those things.